So, what do the results of this trial add to what we already knew about ADVM-022?
So the recent data I presented showed we covered a lot of new things. So number one was cohort one. We saw that the high dose cohort one, which is 6E11 dose, we saw durability. So these were heavily pretreated patients with on average 9 injections before enrolling into the OPTIC study. And after a single in-office intravitreal injection, what we saw that all of the 6 patients went 1 year or longer without requiring any rescue. So 100% of the patients are still rescue free in cohort one. So that was a big deal because that shows durability. The other thing we showed was the first look at the cohort 3 data. So cohort 3, remember, is a cohort where we are not using PO steroids. We're actually using a 6-week prophylaxis with topical steroids. And that was done because we did see some mild early cellular inflammation in cohort 1 and 2, and we wanted to address that. So in this cohort, we have 9 patients, but as of April 1st data cutoff, we only have 6 patients who are past their prophylaxis, and the other 3 are still on it. So we looked at number one, how they did in terms of inflammation, and as of April 1st, out of 6, only 1 patient was on topical drops, which is great news, meaning that we are addressing the mild early inflammatory response with topical drops in majority of the patient. The other thing we noticed was that the BCVA gains and CST reduction is more significant in this cohort. And part of this, because the baseline characteristics, these patients had less duration of the disease and thicker retina. So I think that's the bottom line, is durable response in high dose and addressing the inflammation in cohort 3 with topical drops.
All right, thank you for that. And now, as we move forward with ADVM, what would you like to see next in terms of treatment of wet AMD from this agent?
So I think what we're doing is we are enrolling cohort 4, which is the high dose with topical steroids. So in cohort 4, if we see that patients continue to be injection free like the high dose cohort 1, as well as inflammation is controlled like cohort 3 with topical drops, then I think this program is really exciting because, in my opinion, this could be a game changer, because here you have patients who have 9 injections in the last 12 months, and you give them 1 injection of in-office intravitreal gene therapy, and now they're injection free for 1 year or longer. I think that will add a big value to our patients, and I think that's going to change treatment course, because we know that all patients in real world, from all the database studies, like the one I showed, CRIMD study I did, that patients lose vision. They don't gain vision. So if you have a durable treatment with efficacy, then I think it's going to be very good for our patients in maintaining and treating this disease. And I'm also excited about 022 value in patients with diabetic retinopathy, because remember, those patients are even more non-compliant, and they also go blind from the disease, the #1 cause of vision loss in young working adults.
How much excitement does this add to the discussion around gene therapy as a potential treatment for AMD?
I think that's a big deal. Approval of Luxturna guided gene therapy, to be looked at for treatment of retinal diseases. Of course, Luxturna, you're treating RP65 and replacing a missing gene. Here, you're making a biofactory in your eye using gene therapy. And I think ADVM data, you are seeing 1 year and longer efficacy. You saw REGENXBIO data. Of course, that's a surgical procedure, but you did see that in their cohort 3 at 2 year, half of the patients were injection free, and they continue to have good protein levels. So yeah, in short, I think gene therapy will be the future in treating neovascular AMD and other retinal vascular diseases, because the current paradigm of frequent injection clearly is not giving us the optimal visual outcomes that we want in our patients. And of course, the treatment burden aspect is huge. So I think is going to be a game changer for patients with retinal diseases. And I can't wait 5 years or 6 years from now when that's going to be a possibility, where I can tell a patient, hey, we actually essentially have a treatment where most patients could be one and done. And I think they'll take it much better than currently, where we just tell them we have a treatment, but you have to come in every 4 to 8 weeks.